So in part 2 of GIT, we'll cover two topics, and both are these two topics are important not only from pharmacology point of view, in clinical medicines also you will keep on reading these two topics. One is your constipation and other is your diarrhea. So we have drugs. Suppose there is some constipated hard fecal mass. To remove this, we use the drug. And the other case is, suppose there is a condition where the diarrhea is there. So in case of diarrhea, there will be loss of sodium, potassium, chloride, and bicarbonate. If bicarbonate is lost in the feces, then inside the circulation there will be acidosis. So these are the two portions where we treat the constipated hard fecal mass, and in this case we treat the diarrhea. So starting with the constipation. In case of constipation, we have mainly two types of drugs. One we call laxative and other we call purgatives. Laxatives, they make the stool semi-solid. They make the stool semi-solid and they are related with watery diarrhea. Or purgatives make the things more watery and more fluid type. So their action is called mild action. Laxatives are mild in their action. They just make the stool semi-solid, and purgatives, their action is strong. Why strong action? Because they make the feces in watery form, more fluid accumulation, and evacuate the bowel. So purgatives are strong, are also known as they are also known as strong laxatives. So this these two different class of drugs, they are similar to your sedatives and hypnotic drugs which act mildly. We call them sedatives, and if we increase the dose, what they become hypnotics. So similar to that concept, we have laxative, mild action, we have purgative, strong in action. They make the stool semi-solid and help in the evacuation of the stool, passing of the stool in semi-solid form. So what are the indications for the laxative and purgative? Where we use these two category of drug. So the first indication, obviously, constipation. This is the constipation, and second is to decrease the straining. To decrease the straining. If there is straining at passing of stool, that may increase intra-abdominal pressure, and that may lead to some conditions like hernia. So to prevent these hernia-like conditions, to decrease the straining, we use laxatives or purgatives. That is one indication. Another is obviously your constipation. So the first class of your laxatives, they are lubricant. They are lubricant laxatives. The term lubricant we use mostly for the oil. So oils act as a lubricant material. So what are the oils? They are nothing but some long chain hydrocarbons, like long chain hydrocarbons. So they have lubricant property, oily property. If this is the GIT and this is the hard fecal mass present in the GIT, they will coat that hard fecal mass. The oily coating lubricate and it will help in easy removal or easy passing of your stool, because now the stool has become lubricated because of the oil. So the example for this lubricant is your lubricant liquid paraffin. Liquid paraffins, we call them mineral oils. These are the mineral oils, lubricant. So their mechanism is just, this is the fecal mass, just to coat it. So mechanism of action is coating by oil, and it will easily pass the stool out. The second simple class of drug is your stool softener, also known as surfactant. They may be ionic or non-ionic, ionic and non-ionic. We have two examples. Ionic is your Dacusate, and we have non-ionic class of drug. That is your Poloxamers 188. That is your Poloxamer 188. Then what is the mechanism of this tool softener and surfactant? The mechanism of action is very simple. They decrease surface tension. They decrease the surface tension. So stool softener or surfactant, suppose this is the fecal mass, this is the fecal mass in the GIT. Their mechanism is to decrease surface tension, and it allow water, fat to penetrate. So water will penetrate, fat or lipid material will penetrate inside this hard fecal mass. So once it is filled with the water and oil, it becomes soft. So we call this category of drug a stool softener, because they make the stool soft. How do they make? They decrease the surface tension. They allow the penetration of water, oil into the hard feces. And once it becomes soft, easy to pass. So these are your surfactant, ionic, non-ionic. Ionic is your Dacosate and non-ionic is your Poloxamer. Then the next class of laxative, they are called bulk purgative. Bulk purgative. What is the meaning of bulk? Bulk means more in amount. You can say more in volume. It means this is your hard fecal mass, constipated, and we are giving something in the bulk. So we take water, sufficient amount of water, plus we take your bulk agent. What are these agent? Like bran, like your isbagol. The specule is known as psyllium, Indian specule. So, and one more is artificial methyl cellulose. Methyl cellulose, also called CMC, carboxymethyl cellulose. So these three burn psyllium and CMC. What are they? They are bulk percative, means they are given in high amount bulk, and with that bulk, what is important to take water. If you take less water and more your bulky agent like your isopagol, then what will happen? Instead of treating your constipation, the agent will itself cause constipation. So the first requirement, adequate amount of water is must for your bulk purgative. Then the mechanism of this bulk purgative mechanism. So bulk purgative mechanism of action. Simple mechanism, they hold water with it. So this is the bulk purgative. They are they are hydrophilic. They are hydrophilic. It means whatever water we have given with them, they carry, they hold that water with them. So this is the GIT where the hard fecal mass is there. If you give your bulk purgative, which is holding the water, when it comes at this point of time with water and bulk, that may lead to that may lead to distension of the intestine. That may lead to distension of the intestine because of the bulk. Because of this distension, there are some mechanoreceptors. Mechanoreceptors. That receptors are located in the wall of the intestine. If you distend the wall with the help of all this bulky material, you distend the wall, this mechanoreceptor becomes activated and they give a reflex. Because of this reflex action, peristalsis increases. Peristaltic movement increases, and that will help you to pass the stool. So bulk purgatives are hydrophilic. They love the water. They hold the water. So if you give this molecule, they hold the water, come in contact with the hard feces, then some bulky things occur. All things become bulky. They will distend the intestine. Then these mechanoreceptors are stimulated. They will give the reflex, and that reflex is your increase in peristalsis. So, after increasing the peristaltic movement, we can pass the stool very easily. So, these are your bulk purgative. And the requirement for bulk purgative is to give sufficient, plenty amount of water with them. Otherwise, they will itself cause constipation. And one more indication for bulk purgative, it was uh, impaction colic in case of horse. So we give their psyllium. In case of impaction colic, psyllium is given. Next category is osmotic purgatives. We have OP, osmotic purgatives. They are of mainly two types. Very simple. One is inorganic, other is organic, also called them carbohydrates, organic molecules. So inorganic are your magnesium salt. That may be magnesium hydroxide, your sulfate, your oxide. So these are the magnesium salt. Osmotic purgative, inorganic or organic. Inorganic are nothing but magnesium salt, and in case of organic, we have carbohydrate. Which carbohydrate we have? Lactulose. Lactulose is a derivative of your lactose, and the other one is your mannitol. Mannitol, and there are many. So these osmotic purgatives, inorganic, organic, magnesium salt, carbohydrate derivatives like lactulose and mannitol derived from the mannose. This is from the mannose. So what is their mechanism of action? As the name indicate, they are osmotic purgatives. It means there is something to related with the osmosis. If we compare osmotic purgative with our bulk purgative, then there is a small difference, little difference. These molecules, when they are present in your GIT, this is your osmotic molecule. And bulk purgatives, this is the bulk purgative. They are hydrophilic. Hydrophilic. Whatever amount of water is drink, whatever you drink, that they hold. Means they retain or they hold water. But in this case, they extract the water in the lumen. This is the difference. They extract water into lumen. It means whatever water is present in the inside the body of the animal, they try to pull it, they try to extract it into the lumen. So pulling or extract water into the lumen. And because of this water, stool can be passed without any much straining. So this is the difference between bulk purgative and your osmotic purgative. They hold the water, but they pull the water. They extract the water into the lumen. And this water is the water of your body, not from the outside. So what is the contraindication? The contraindication is, suppose your animal is weak and it is dehydrated. So in that case, contraindicated. Osmotic purgative are contraindicated because what they are doing from the intestine itself, they are pulling the water. They are pulling the water. If the animal itself dehydrated, then no use of giving this osmotic purgative. So this is the contraindication. Weak, dehydrated. Something more important about this molecule like lactulose. One important thing is that they are not digested inside the GIT. If we give lactulose, it will enter small intestine, then large intestine. At this place, there are microbes. These microbes break down lactulose into lactic acid, acetic acid, formic acid, other acid. So lactulose produces these metabolites at the level of large intestine, and these act as osmotically active molecule. They pull the water into the lumen. So this is related with the bacterial digestion, where lactic acid, acetic acid, and other acid are formed. So because of osmotic effect, this molecule attract water. One more thing, all these are acid. It means they will decrease the pH. So what is the effect of decreasing pH? This decreased pH will increase motility. That is also good for the constipation case. Another thing, it also increase secretions. So with the lactulose, we are getting three benefit. One, they are producing metabolite which are osmotically active. They will pull the water in the lumen. And the second thing, these acid decrease the pH, and that will lead to increase in motility and increase of secretions. So three benefit. The feces is here, hard feces, we increase the motility, we increase the secretion, and we pull the water. So all these things may lead to passing of the stool very easily. So these are two other benefit advantage from the lactulose. But not only this, there is one more advantage of using lactulose. We use lactulose in case of hepatic encephalopathy. What is that? Normally, this is the liver. Liver convert ammonia into urea. This is the normal function of our liver. But if the liver is damaged, there is chronic liver disorders, then what will happen? Ammonia will not be converted into urea. This ammonia will enter into blood. From the blood, see, ammonia is lipid soluble, it can cross membranes. From the blood, it will enter CNS, and that may lead to coma. So we call this a coma type condition because of damage to liver. Because of damage to liver. So there is encephalopathy, damage to our brain because of hepatic, because of liver. So we also call this condition hepatic coma. So the normal function of liver is to convert ammonia into urea. If liver is not working properly, ammonia will accumulate, enter into your blood, from the blood enter into your CNS and lead to coma. That is encephalopathy because of the liver. So hepatic encephalopathy. Coma condition because of the liver, so hepatic coma. So how to protect this? If we do something related with the ammonia, if we stop ammonia to enter into blood, then it will not able to enter here, CNS. So at this step, if we remove the ammonia, then the whole problem will be solved. So how to remove this ammonia from the body? See, removal of ammonia is a function of liver. But at this point of time, your liver is not working. But we want to remove this ammonia. So how to remove? We give our molecule lactulose. We give the molecule lactulose. So what is the role? Suppose this is the intestine. This is your intestine part. Which one? Large. Where ammonia is produced by the bacterial activity, what we give? Lactulose. Lactulose break into two molecules, H plus and lactulose anion. This H plus comes and combine with ammonia molecule and it will form NH4 plus. And as from the general pharmacology, polar molecules never cross and they will not reach to blood and they will not reach to your brain. So what is the fate of this NH4 molecule? It will come into the feces. So in this way, we have removed the ammonia. Instead, our liver is not working. The liver is not working. It is not able to convert ammonia into urea. So what we did, this excess ammonia at the level of production, we add some H ion, make it NH4 plus, and that may comes out in feces. So lactulose is used for the hepatic encephalopathy or hepatic coma like conditions. So in clinical medicine also, in case of liver and pancreas portion, this lactulose will come again as a drug for your hepatic encephalopathy. Then next comes irritant, or we call them stimulant. Irritant or stimulant purgative, also called as contact purgative. So their name is purgative, means they are strong in action. They are not making stool semi-soft. They will lead to watery evacuation of this. So, as the name indicate, irritant, it means they will irritate the GIT mucosa. So this is the main mechanism, irritate the GI mucosa. And because of this irritation, what will happen? Purgation. There will be purgation. And there is one minor mechanism also, not important to remember, but still, this minor mechanism, they block sodium potassium ATPase. Sodium potassium ATPase, where obviously in the intestinal villus cells. So as an irritant purgatives, stimulant purgatives, they are of three types. One is your direct, second is indirect, and third one is drastic. They are the three category of irritant or stimulant purgative. One direct acting means directly irritate, they directly irritate the GIT. Then just example, the best example is your bisacodyl. Okay, bisacodyl, and another if you want to remember phenolphthalein. But this is more important. Bisacodyl is a direct irritant purgative. Then in the category of your indirect ones, indirect means what? As the name indicate, indirect means they require activation. They are not direct. If I give you one example, in pesticide, we have studied organophosphate, direct acting and indirect acting. Direct was phosphorus double bond O and indirect carry phosphorus double bond S. Indirect acting require activation and in the liver means becomes PO. Then it will act. So this was in pesticides, direct acting, indirect. Similarly, irritant purgatives, Indirect acting, they require activation to do the irritant action. So what is that indirect action? So in case of indirect acting, we have vegetable oils. What we have? We have vegetable oils. As you remember from biochemistry point of view, vegetable oils are nothing but fatty acid plus glycerol. This is the structure of oil. This is the structure of oil. So they are indirect. It means they need activation. How to activate? We use pancreatic lipase. Pancreatic pancreatic lipase. It will break the oil into it will break the oil into fatty acid and glycerol. So this fatty acid is responsible for the irritant purgation. Irritant action. So indirect purgatives are the vegetable oils. Oils are nothing but triglycerides which are having two parts, fatty acid and glycerol. This is our GIT. Suppose oil reached here and this is the pancreas giving you pancreatic lipase. So this pancreatic lipase, it will break our oil into two parts, fatty acid and glycerol. So fatty acid, if this is castor oil, okay, castor oil, then the fatty acid name will be something ricinoleic acid, like ricin. So it will irritate the mucosa. Then as a byproduct, what we get? Glycerol. This glycerol molecule is also having some action. What is that action? Lubricant action. Lubricant action. So in case of the indirect acting, vegetable oils and castor oils are there, which are nothing but fatty acid with glycerol. If the molecule reaches here in the intestine, pancreatic enzymes will come lipase, break them apart. Fatty acid act as a irritant purgative. Glycerol molecule will act as lubricant. So from one compound, we are getting double action, irritant purgative action, and we are also lubricating the fluid or feces. So in this way, we can pass the stool very easily. So these indirect purgatives, the first member was your oils, and there is second member. The mechanism remains same, but they ask anthraquinone. Name of the class. Just remember at least two examples: cascara and stem. These are natural ones, and there is one synthetic that is called dendron. This is dendron. This is not dentroline. If you remember, there is one drug, dentroline, that is drug of choice for malignant hyperthermia in case of pig. So dendron is indirect purgative, but dentroline, this is drug of choice for malignant hyperthermia in pig. Malignant hyperthermia in pig. Then the third category was drastic purgative. They are the they are the strongest one. So remember their example, croton oil. We call it Jamal Gota in Hindi. So croton oil, and there are one more gel like this. And as a chemical, barium chloride. Barium chloride is very important because it is drastic target. And next class of our purgatives are neuromuscular purgatives. They are nothing but your cholinergic drugs. They are cholinergic drugs. It means at the level of GIT, we have M receptor. We have M receptors. Cholinergic receptors are of two types, nicotinic and muscarinic. So these are your M receptor, muscarinic receptor, which are responsible for the activity contraction of the GIT. So if you stimulate M receptor, then what will increase? Motility. More the motility, stool come out, easily pass the stool. So these are example your carbachol like neostigmine. These are cholinergic drugs. The next class of drug are opioid antagonist. See, opioid, if you look at the opioid, they may act as central or peripheral. We are dealing with the peripheral receptors. It means we are dealing with the GIT. In the GIT, we have mu receptor, opioid receptor, mu receptor. This is the mu receptor in the GIT. So these opioid antagonists, they will act at the peripheral receptor or your GIT receptors. And opioid, their use is opioid induced constipation, which is also called non-infectious constipation. Not non-infectious, just opioid induced. So one of the side effect of opioid is constipation. If after the surgery, post-operatively, if you administer your opioid drug, that may lead to constipation. Because in the GIT, we have mu receptors, they will act and constipation will be there. So this type of constipation post-operatively, it is called opioid-induced constipation. So the constipation which is induced by the opioid it can be removed by the opioid antagonist. And that antagonists are peripheral, they will not enter into your CNS. So no side effect, no CNS side effect. They will come and work at this place. So what is that drug molecule? That peripheral opioid antagonist. If you remember, there are two drugs, naltrexone and one is methyl naltrexone. We have studied this one. This is your systemic drug. If you inject this, it will come and antagonize the mu receptors. But this molecule, if we combine a methyl group with this methyl group, that methyl group will keep it in the GIT. So orally, if you give methyl naltrexone, it will come at the GIT, and locally, It will block the mu receptor. So this is methyl naltrexone, your peripheral mu receptor antagonist. Not this one, because it is systemically active. It will come into blood and then block the mu receptors. But we want to block receptor only at the level of GIT. The problem is at the level of GIT. Constipation is in the GIT. So peripheral receptors we want to block. So give a drug which is peripherally acting. So methyl naltrexone. Very important. And that indication is opioid-induced constipation. Because post-operatively, if you are using your opioid drug, tramadols, and some other post-operative painkiller as your opioid, that may lead to constipation. Then we have one more category, prostaglandin E1 derivatives. Prostaglandin E1 derivatives. There is one more most important drug that is lubiprostone. This is very important, lubiprostone. The mechanism of action is your chloride channel, chloride channel number, chloride channel protein 2 activator. Activator. Lubiprostone. So what is this chloride channel about? In the GIT, we have chloride channels. Suppose this is the GIT lumen and here we have chloride channel. The role of chloride channel is to throw chloride inside. Chloride inside. See, chloride carry negative charges. The whole GIT from the inside will become negatively charged. To neutralize this negative charge, what comes inside? Sodium. To maintain the electrical neutrality, that is, the negativity is induced by our drug. Which one? Lubiprostone. So, lubiprostone will come and activate the chloride channel. More chloride comes in, things become, the lumen becomes more negative. To make it neutralize, sodium come inside. And with the sodium, always water comes. With the sodium, who come? Water. So in the GIT, you have hard feces, constipated feces, and we use the drug like lubiprostone, increase the chloride, more negative, sodium come, water come, and it will become soft and easily pass the stool. So the use of this drug is idiopathic, means whose etiology is unknown. You don't know what is the etiology. Idiopathic, chronic constipation. In that case, you can use your lubiprostone that act through chloride channel activation mechanism. So this finishes our laxative and purgatives. Next class of drug, they are antidiarrheal. Antidiarrheal. The first is protective and adsorbent. It means, suppose this is the GIT, there is some ulceratives or inflammation. We use the protective, they come and protect this area. There are some sensory nerve endings which are irritated. at this injury area. So we use the protective. That may be your kaolin, pectin molecules. They make a coating to protect it. Another function, adsorbent. If you use activated charcoal, this is the activated charcoal. Suppose there is some toxic molecule, it will adsorb that molecule on the surface. If this is the toxin of your bacteria that is causing the diarrhea, then activated charcoal will adsorb on its surface that bacterial toxin. So this is called adsorption on the surface. So activated charcoal may adsorb the bacterial toxins and prevent further diarrhea. There are protectives like pectin, kaolin, they protect the ongoing injury, inflammation, and prevent the irritation. In this, uh, there is one more drug we call bismuth salicylate. Bismuth salicylate in this category. This drug has two and three more advantages than your kaolin pectin charcoal. What are those? Bismuth, B for bismuth, it is against the bacteria, means it is antibacterial. If the diarrhea causing bacteria are present in your GIT lumen, then your bismuth will kill those bacteria, so antibacterial. But the bad thing about this bismuth is it is nephrotoxic, accumulate in the kidney, damage the kidney, nephrotoxic. One more bad thing is black stool. Bismuth give a color to the stool. And what is that color? Black. That may confuse with the melena. This melena is also black in color. So these are 3 points with bismuth. And this salicylate inhibit COX, inhibit prostaglandin synthesis. It means it is anti-inflammatory, anti-inflammatory in nature. Or not only anti-inflammatory, anti-secretory also. Anti-secretory. All the secretions because of your inflammation that may be inhibited. So remember the 3 4 points about bismuth salicylate. Bismuth against the bacteria. Bismuth give you black stool. Bismuth nephrotoxic. Salicylate inhibit COX, inhibit your prostaglandin synthesis, and prostaglandins cause inflammation, secretions. So all those things will be inhibited. This is your bismuth. After protective and your adsorbent class, there is one category anti-motility. Anti-motility drugs. It means something to do with motility. Inhibit the motility. So anti-motility drugs are nothing but your opioids. Opioids have one side effect. We can use that as our antidiarrheal drug. So and they inhibit the motility of CIT opioid. So opioid they not block, they stimulate the mu receptor and cause constipation type to stop the diarrhea. They are anti-motility drug. The example, just two example, loperamide and diphenoxylate. Diphenoxylate. But the important thing to notice about the opioids, In case of constipation, we were using opioid blocker antagonist, and that was for the opioid-induced constipation. In this case, we are using anti-motility drug, our opioid, at mu receptors in the GIT, like loperamide, diphenoxylate. But this kind of drug, they are mainly used for non-infectious diarrhea. That diarrhea should be non-infectious. Infection should not be present there. Then you can use your opioid. What will happen if you use this drug, opioid drug, in case of infectious diarrhea? Suppose this is your GIT and there is some bad bacteria and it is damaging, releasing toxins and causing the diarrhea. So what we call it? Infectious diarrhea. If you use your drug opioid, it will come and act at the peripheral mu receptor, peripheral mu receptor, and that will decrease the motility of your GIT. If you stop the motility of your GIT, what will happen? These bacteria will stay here for a long period of time. Why? Because the intestine is not moving, no motility. They will keep proliferating. They will multiply, keep proliferating, not going out. That may lead to further infection, further diarrhea. So, no use of opioid in case of infectious diarrhea. Instead, they will worsen the problem. They exaggerate the problem. Because if you do not allow your intestine to move, they will stay here, they will multiply, proliferate more toxins, and things become more worst. So opioids are used for only for non-infectious diarrhea. That is very important. Then the next class for your diarrhea is anti-secretory and anti-inflammatory drugs. Anti-inflammatory drugs. It means there are some drugs which are related with inflammation. They are going to decrease inflammation. That's why we are calling them anti-inflammatory drugs. Also decrease the secretions. So what are those conditions where we want to reduce the inflammation? We want to reduce the secretions. There is one term, inflammatory bowel disease. These are of two types. This is your clinical medicine part, ulcerative colitis and Crohn's disease. Crohn's disease. In both the cases, what is common? This I is common. In both the cases, what is common? Inflammation. Okay. Which part is inflamed? Obviously, from the name itself, colitis means colon is inflamed. Which part is inflamed here? Whole GIT. Every part is inflamed. So, inflammatory bowel disease, disease of the bowel, disease of your GIT, inflammation is there. Both the cases, inflammation is there. But in case of ulcerative colitis, there is colon inflammation. In case of Crohn, whole GIT inflammation in different patches. Hair inflammation, then at this point, duodenum, stomach, some inflammation colon. That is Crohn disease. So why we are studying this disease with the anti-inflammatory? See, this is our stomach and small intestine, and this is the part we call colon. Colon. So in case of IBD, ulcerative colitis, this is the colon which is inflamed. So we want our drug 5-ASA. This is the drug. We want this drug to come at this place and remove this inflammation, reduce this inflammation. But the problem with this 5-ASA, this 5-ASA will not reach here, it will absorb. It will absorb at this point of level. So 5-ASA need alkaline media. This will work in this point, at this point, colon. So if you give 5-ASA, it will absorb at this point into the blood. So what we did, we make such molecules of 5-ASA so that it will reach at the site of colon. That 5-ASA, with the help of this bond, so this 5-ASA, so the 5-ASA molecule, with the help of azo bond, it was combined with another molecule, and that molecule was sulfur pyridine. Sulfur pyridine, and the product name was sulfur saline. So now this sulfur saline will not absorb from this point, and then it will reach at this point and reach the result. So 5-ASA with the help of azo bond, it was combined with sulfur pyridine and product was sulfur saline. It was given, not absorbing from stomach, it reached the colon. So out of this 5-ASA, so sulfur saline contain 2 molecules. We have prepared sulfur saline ASA with sulfur pyridine. This ASA will inhibit the COX enzyme and decrease prostaglandins, and that will decrease inflammation. So this was the problem. In case of inflammatory bowel disease, there was inflammation. So to decrease that inflammation, we need inflammatory. We need, we need inflammatory anti-inflammatory. So this 5-ASA molecule. This is anti-inflammatory inhibition of COX enzyme. But this extra molecule, sulfapyridine, is of no use. We are using it as a carrier, and it will cause unnecessary toxicity. So the second molecule was synthesized. First was 5-ASA with sulfapyridine. This was your azo bond. Then second 5-ASA, this was removed and we did one filtration. What was added? Filtration. Means coating. What kind of coating it was? Acidic coating. Now the drug enter into GIT 5 years. It will not be destroyed in the stomach. It will not absorb because this protein it will dissolve in the intestine and our drug will work. So in this way, that one molecule was synthesized by combining 5% with a membrane or coating, and that molecule was the cell. This was the cell. Then after sulfasalazine, that is 5 years, sulfasalazine, we come with one new drug in salad. Therefore, 5 PSC was quoted in the membrane and the report. Then one more drug came. That was osalazine. In this osalazine, two molecules of 5 ASA were combined with the help of azobone. Osalazine. So in this case, no need to add this carrier, this entry coating material. Only 5 SA is. But the problem was this add for this osalazine was we are adding two molecules. So it will further increase the. So the next was osalazine. Here. In this case, what we did 5 was combined with a non-reactive molecule. Um, absorbed from the stomach, and it will be excreted out. That molecule was in the five amino acids beta and so in this way there are four drugs to treat the inflammatory bowel disease, ulcerative colitis, means inflammation of the bowel.
हेलो सर, वॉल्यूम क्लियर नहीं आ रहा. हेलो 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 सर, वॉल्यूम क्लियर नहीं आ रहा सर आपका.
अभी आ रहा है
क्लियर अब. हाँ, अभी आ रहा है, अभी आ रहा है सर.
So, inflammatory bowel disease, there is inflammation of the bowel. At which part? Colitis. So, this was the molecule was 5-ASA. It will inhibit the COX enzyme, decrease the prostaglandin synthesis, and increase the inflammation of colon. This was the main aim. But with this molecule, the problem was it was destroyed in the stomach itself. It was unable to reach at our target site colon. So what we did, first we added sulfapyridine and made our drug sulfasalazine. But in this way, okay, the molecule is entering our colon, but we were adding this extra molecule that was not required. So we removed this. Then what we did,
सर,
we
अब
make a
माइक पहले अच्छे से करो सर. माइक अच्छे से करो सर जी. थोड़ा रुक रुक के आवाज आ रही है, थोड़ी रुक रही है फिर आ रही है, रुक रही है आ रही है. तो माइक थोड़ा अच्छे से करो.
Hello. Hello.
हाँ, क्लियर है सर, क्लियर है आवाज.
Clear as? Okay.
यस सर.
So this category of drug was for the inflammatory bowel disease, mainly the laxative polymer. So the main molecule was to reduce the inflammation, but it was combined with different formulation. First with sulfapyridine, then we remove this and we add a coating, the drug becomes me7C. Then the next preparation was we combined two molecules with the help of azobone. But with this molecule, what we added one more drug. So the concentration becomes double. So we remove this also. Then we come with a new preparation that was with 5-amino benzoyl beta alanine. This molecule will not react or it will not do any harmful effect. It will simply excrete out from the food. So with this IBD, the whole problem was with the colon, ulcerative colon. Our ASC was unable to reach this site and it absorbed in the blood. So to make it reach here, we did four type of modification. Adding sulfapyridine, then making a coating, and then adding one more molecule, 5-hexadecimal, and at the end we come with a better option that will excrete out of the body. So these category of antidiarrheals, they were related with the anti-inflammatory, and in sequence these were modified. Like, then the next category of antidiarrheals, they are astringent. The next category of antidiarrheals is what are astringent? They act as surface. Surface. What is surface?
सर आवाज रुक रुक के क्यों आ रही है सर आपकी, ये समझ नहीं आ रहा.
Precipitation. Are you? Hello.
हेलो सर, आवाज थोड़ा रुक रुक के आ रहा है सर आपका.
So astringent molecules, they act at the surface and the mechanism of action is the protein precipitation. Suppose this is the part of the GIT where there is some damage, inflammatory damage or some ulcer, then these astringent, they will come and precipitate the protein here. That precipitation will act as a barrier. It will protect that area in the form of a barrier and there will not be any further damage. So the area becomes healed within a particular time. So astringent, their mechanism is protein precipitation at the surface. If this is the surface of your intestine, that they will precipitate the protein, make a barrier, and try to. Examples may be natural one like tannic acid, like potassium. But there are some metallic preparations also. These are not used nowadays because they are toxic, but examples like copper sulfate, zinc sulfate, some aluminium compound, and some iron sulfate. These sulfate are the metallic astringent. Act at the surface. Mechanism is protein precipitation. Because of protein precipitation, they will form a protein here between the suppose there is endotoxin. It will not allow endotoxin to enter. It has a tag. They are active. Then the last topic of antidiarrheal. That is what but what is important for the ORS? Suppose there is diarrhea. There is diarrhea. In the diarrhea, what we are losing sodium, potassium, chloride, and bicarb. We are using bicarb in the feces. So blood becomes acidic. So if you lose the bicarb, there will be metabolic acidosis. So this is the problem with the diarrhea. So in case of ORS, what we are doing, we are adding sodium, potassium, chloride, and bicarbonate. And one more thing which we are adding is the glucose. See, these all things are lost in the urine. This is so we are adding sodium, potassium, chloride, bicarb, and one more thing extra. You need to remember glucose. In this case, the role of glucose is not to provide energy. It doesn't provide energy, but the main use of adding glucose in ORS. This is your intestinal cell. Here is one pump, SGLT, means sodium and co-transport. So the function of the glucose in your ORS is this, to facilitate sodium absorption. So this is the function of glucose in ORS production, to facilitate sodium absorption. Then in case of ORS, we add citrate, we add carbonate, the role of these drugs, these compounds, if you add sodium citrate in ORS. See, as the name implies, sodium citrate. So the name it is acidic, but in reality, sodium citrate is not. These citrate bicarbonate, they are alkaline. They are alkaline. So what is the role of adding citrate or bicarb in the ORS? In case of diarrhea, we lose alkali. And what is left? Metabolic acidosis. To treat this metabolic acidosis, we add citrate in the ORS. So if I summarize the ORS, only electrolytes and HCl potential. Then we have citrate to the metabolic acid. And then we have glucose to facilitate sodium entry into the cell. Not only provide an energy, it will help to facilitate sodium entry. So this is the ORS and